Thank you all very much. It's an honor to come out and address the Service Hippy group. You all have done such a great job of getting information out to people. You know, it's good to go out and look on the internet, but you know, we give a biased type of data because that's what we do, and it's always good for people to be able to go to a group that is patient-driven, where they sort of get an unbiased view and patient's perspectives, which are a little bit different than a surgeon perspective. So it's really great that this group exists, and we may need to harness this group in the near future to do a little lobbying in Washington, because I fear that resurfacing is under threat right now, and you all know of all the potential the problems that have been reported, and the media frenzy that's developed, and the even the total misunderstanding by most surgeons about what the problems are. And there are problems for sure. And so I thought at this point it would be a good time to talk about those. It's a very, very complex, multifaceted topic, though. It's, you know, you can't just give a quick answer. And most surgeons, unfortunately, have almost no understanding. And they this sort of the idea that sort of permeates orthopedic experts, joint replacement experts' opinion right now is that all metal bearings are bad. And that's very unfortunate, because if the FDA doesn't stay reasonable, they could basically drive all the manufacturers out of offering these in the U.S. It's already come to pass with Wright Medical. They were bought by a Chinese company, and they've decided to stop selling their implant in the U.S. They're still going to sell it in Europe, but the legal climate in this country is just too crazy for them to want to sell it anymore, because all they need is a few lawsuits, and then it's going to cost them millions of dollars. So they've already pulled out. So and the FDA may be requiring manufacturers to do a whole other round of studies, which are so expensive to do that they may just decide it's not worth it. The money's not in it for us. We're not going to do it, and then we lose one of the best hip operations there is. So that's a very depressing note, and I'm really, really concerned about that. And I'm contemplating sort of developing some sort of a grassroots campaign to talk to our congressmen and the FDA and put some pressure on them so that they know that we still want this operation around. Just because a couple companies made some mistakes and a lot of surgeons don't really know how to do it right doesn't mean that it's not a good operation. So I've got some sort of really complicated, sort of negative type of talk, and then I've got, if we want to still go into it on the end, sort of the positive notes and what we've been doing. The bottom line is, if hip resurfacing is done right, there's no hip replacement that can come close to it. But it's easy to goof it up, and there's certainly a lot of examples of that. So next, let's go ahead and try to zip through the first section. I'm going to say next, and you hit the next button, Lee. Okay. So these are the kind of things that people are saying. I'm concerned that these can cause cancer. Pseudotumors are severe complication caused by metal allergy. They cause muscle destruction. Revision surgery for this problem has a poor outcome. And the metal is corroding and poisoning my body, causing numbness, heart problems, weight loss, hearing loss. People are scared about this stuff. The media's whipping this up. Lawyers are going crazy. Just go on, next. So what are the real problems? These are the things we're going to address next. First thing you have to understand is that any artificial joint you put in your body is not natural, and it's going to put particles out there. The question is really, what's the science behind it? What actually happens with these particles? And any kind of hip replacement doesn't make you a normal hip. And I think a resurfacing gets you closer, but they're not perfect. So metal bearings put off cobalt and chromium. Metal polyethylene particles put out polyethylene plastic particles, and a small amount of cobalt chrome as well. And ceramic particles, ceramic on ceramic bearings put off ceramic. Next. Ceramic is, even though I'm biased towards metal, I would say ceramic is the best wear debris. If that's the only issue, I'd have ceramic. But you can only have a total hip. Maybe in the future we'll have ceramic resurfacing, and then that's a whole other topic. But you can only have a total hip, and small bearings are unstable, and there are also wear problems with ceramic. They're just not particle-driven pain, swelling, or bone destruction. They are rather loud squeaking that you can hear across the room. There are 1% to 2% problem with ceramics, but they do require revision sometimes. Occasionally ceramics fracture, and they cause significant problems. And most of the reports of cobalt toxicity, there's only 6 reports of cobalt toxicity in the literature. 4 of them are due to ceramic bearings. Only 2 are due to metal bearings. So if you are worried about toxicity, you shouldn't have a ceramic bearing. Those are the ones where that's been reported. But these are a few case reports and thousands of this is ridiculous. It's bizarre. Go to the next step. Okay, so what about plastic debris? Plastic debris can cause problems. That's been our traditional problem. It causes bone destruction, which we call osteolysis. It can happen with metal debris too. Fortunately, with the newer cross-linked polyethylene, that's much less of a problem. That's mostly a solved problem. But we only have 10-year studies on small series with the small bearings, and they seem to wear very well and cause very minimal or no osteolysis, but we still have the instability problem. It's not a stable hip joint. It's not a normal hip joint. It's far from a normal hip joint. We're going to large. When I use polyethylene, rarely I use a 36 bearing with cross-linked poly. The bigger the head, the smaller the plastic. The wear seems to be okay with these new cross-linked poly, but you still have the issue of breakage. Are they going to break? And for sure you wouldn't want to run and jump on a thin plastic. So there's theoretical problems with these, but this right now, if I do plastic, this is what I use. I think it's the best balance right now, but the long term, we don't have 10-year data on it yet. Okay, next. So what are the real problems with metal bearings? Cancer risk? No, there's no evidence. That's a bunch of bull. What about the patient's life? Does it make people die sooner? No. Actually, there's some evidence of the reverse. Does allergy exist? There's no evidence for it. People have some crazy ideas about that. Surgeons have crazy ideas about this. Systemic toxicity, possibly at high levels, but few case reports, very little evidence. But there's a maybe on this if you have really bad wear. Adverse reaction to wear and debris, yes, that's a real problem. But it's fortunately a rare problem with good implants and good surgery, and it's totally preventable. Next. So a number of articles have been done looking at cancer risk long term, and they all conclude that there's no cancer risk over the long term. Next. McMinn did a study using the Australian registry comparing total hips to BHR resurfacings, and actually there's a higher mortality if you have a total hip. So if this was the reverse, the media would be on this saying metal poisons you and kills you, but no one says anything about this. It's probably not significant. There's probably some bias somehow that's causing this, but basically we can't show that these things are killing people and there's no cancer risk. So I think the metal's probably benign as best we can tell. It doesn't cause any systemic problems. Next. Recent review article in the JBJS concluded that there's no evidence that allergy causes any clinically significant problems, that it even exists, and that's my opinion, but people have different opinions about this, but it's not based on evidence. Next. What is this idea of allergy based on? Somebody who did a study showing some unusual findings on tissue examination, pathologic evaluation of metal hips, and some unexplained swellings of hips. But just because you can't explain readily why there's a swelling doesn't mean it's an allergy. That's kind of a leap of faith. Let's go to the next one. So what's the evidence against allergy? Women typically wear more jewelry than men, and a lot of women have a skin reaction to cheap jewelry that contains nickel in it. And that's a very common skin sensitivity. And you can do a skin patch test if you want to test for that, but there's no correlation of that with problems with the implant. So people with well-functioning total hips, about 20% of them have a positive skin patch, and people with problems have 20%. It's not predictive, so and neither is lymphocyte transformation tests. These are the more sophisticated blood tests that they've been doing at Rush University and other places since for over 10 years, and they've still never published any study that predicts it. So you have a certain... You get the lymphocyte test and you say, oh, you're allergic to this metal, and then you do a hip or a knee implant, and then you have a reaction. They can't demonstrate. No study has shown that there's any predictive value to these tests. So you would think someone would have done that in 10 years, but so still no evidence. But people still go out and get those tests and then try to base decisions on that. I think it doesn't make any sense. It's been shown that total knees, which have a cobalt chrome femoral component, but they're not a metal bearing, have metal ion levels that are mean of about 3, which is what a lot of well-functioning resurfacings have. And there's over 400,000 of those done a year in this country. They're virtually all cobalt chrome. There are some others you can use. There's no concern of allergy to total knee. So if you're having 3 micrograms per liter of cobalt chrome in your blood with a total knee and not being allergic, why should you be allergic if you have that same level with a resurfacing? There's a logical disconnect here. Even Josh Jacobs from Chicago recently published that that hybrid total hips also have a slightly higher cobalt level than baseline. It doesn't go out of the normal range. It's much lower. But if you were allergic, if you're allergic to peanuts, you don't need to eat a bag of peanuts. You need to eat a crumb of a peanut to have an allergic reaction. So all this speaks against the idea of allergy. Next. It goes back to Willard's report. He had some metal bearings that were revised, and they didn't have metallosis, and they didn't have loosening that they could tell, but there was this unusual histology, which he said looked like an allergic reaction, and this was later called alval. So people think this means that there's an allergy, but that's pretty slim. That's a pretty dubious evidence, I would say. Next. Then there was an Oxford pseudotumor report, and they got it all wrong. But there's a bunch of surgeons there, there's a bunch of residents and fellows, inexperienced surgeons doing these cases. They don't have a lot of experience, although their total number is pretty high. And they had all these cases of unexplained swellings. They used good implants, by the way. They didn't use the Durham or the ASR. They used good implants. They used the BHR and the Wright Medical mostly. And they had all these unexplained swellings. They claimed their acetabular component positions were acceptable. That's not true. They're not telling the truth. And they don't know whether metallosis was present because they did retrospective chart analysis and they didn't record this stuff. So there's no mention of metallosis in their article. They didn't do ion levels. They didn't do allergy testing, but they speculated that allergy may be the cause. And even went so far to say is women seem to have more of the problem because they might not be sensitized because they wore jewelry before or something. This is wild speculation. This is craziness. Go to the next level. And then they analyzed later 8 of these 26 implants they still found lying around somewhere, and they analyzed them. And if you do careful analysis, you can see where the wear patch is on the cup. And if it's at the edge, we call that evidence for edge loading. That means the cup was placed in a bad position if it's edge loading. A cup that's wearing properly, this is all stuff that's developed after their initial study. But if you put a cup well, the wear patch should be buried within the cup. It shouldn't be at the edge. And that's what produces a well-functioning cup. We now know. A lot of the stuff we didn't know before 2006. So 8 of their implants showed edge loading. They didn't analyze all 26. But in this follow-up paper, when they did this, they said, well, the X-rays in these were not good enough to compare this to component position on X-ray. Well, the X-rays were not good enough here, but they were good enough to say that their X-ray positions were good in the previous study. It sounds really fishy to me. So they really misstated the facts in the first paper. Their X-ray positions probably were not okay. And of course, you don't publish the actual pictures, so I don't believe them, and hardly anybody believes them.
Was it post-mortem analysis?
So those were studies of implants that were removed, and they studied where the wear patches were by scanning EM. I forget the exact technique. It's not scanning EM, but you can find where the wear patch is. There's a profilimetry machine, and you can find it. So here's the Oxford story: 4% pseudotumors at 8 years, catastrophic complications with dire consequences. Component positions are not related to failures. In other words, it's not our fault. It's the implants, or it's something else. It's magic. Allergen may be the cause. But edge wear was seen on 8 out of 8 components they analyzed. That means the components were bad. They recommended, because they thought it was allergy, they were working under the wrong hypothesis, that aggressive debridement of every little bit of metal should be done, and that you should convert it to a non-metal bearing, to a metal plastic bearing, so that you won't have that further allergy response. Well, when they did this, they then published horrible results. And then they said, oh my God, this is such a horrible problem. They didn't stop to think that maybe they weren't dealing with it properly. But so, first of all, they didn't really understand what the problem was. And then when they tried to fix it, they created huge problems. Next slide. So I've done 3,500 cases, and I've done over 100 revisions. I have seen, never in my practice, seen a catastrophic case with a dire consequence. I have, if you look at the surgeon experience here, that's the difference. I've done some wear revisions, and they all turned out perfect, and they didn't have any complications at all. So I still have yet to see a case of one of these muscle-eating, horrible, destructive things, and I've never caused nerve damage or artery damage or anything like that in these wear revisions. So they are a problem, but they're not really much worse than a loose cup or any other complication with the hip replacement. All right, next. So they use this term pseudotumor, which means an unexplained fluid or soft tissue mass. It's not a cancer, but it sounds a little scary. Next. I think it's a bad term because it just means we don't know. We have a swelling we don't know. And it leads to fear among patients, hysteria in the media, poor scientific studies, because if you study a symptom, you're not really studying a problem. You first got to figure out what the problem is. Is it a wear problem? And then you try to figure out what causes them. If you have a loose component, you study what causes that. You don't just study all people with swelling, because there could be lots of causes for swelling. So that's just a bad way to do studies, and it's led to a lot of nonsense in the scientific literature. And it also may lead to uninformed regulation by the FDA, and it may end hip resurfacing in the U.S. So these are the known failures of hip replacement, and you can get these kind of things with hip replacement and resurfacing. The wear problems exist with both. With plastics, it was more bone destruction, but you also get tissue inflammation. With metals, you get a little bit more tissue inflammation and a little less bone destruction, but you can get both. Next. What happened to the other slide? That's bizarre. Go back and forth again. There's two pictures there. That's bizarre. This morning, or last night I looked at it and there are two pictures. Now there's only one. Well, this was my...
Try hitting going forward, see if the other one shows up.
That's bizarre. All right, so this is my first wear failure case, corn resurfacing that I took out. This is the metal in the tissues. I didn't take any muscle out. This is just inflammatory tissue I peeled out. She's, 5 years out from this revision. She had wear failures on both hips. My first two cases, and she's doing fine. I revised her to a metal total hip, and her iron levels are back in the normal range, and she's doing fine. What I was showing you was a metal plastic revision on this side, which has just as much debris in it from plastic debris, which I took out. I mean, it really is not that different. And the problem with the plastic one, there's more bone destruction. That patient with the plastic wear revision actually had 2 more revisions after that because I couldn't get good fixation on the damaged bone. There was so much bone destruction. But that's anecdotal. You can basically have a similar amount of tissue inflammation with both types of wear processes. So what are most pseudotumors actually? They're not allergy problems. They're just tissue inflammatory response to excess metal debris. So if we have an abnormal wearing implant that's putting off too much metal, you can have a reaction. And it's not an allergy. Some people may react more than others, just like if I took a handful of dust and blew it in your eye. Everybody's going to have an inflammatory reaction. It's going to be painful and red and sore, and it might last a day or 2 or 3. One guy may need steroid drops and have a real big problem. Another one get over it in a day or so, right? You have a different response, but it's just putting dust in the wound is the way I think of it, and it can cause an inflammation. Some people have a little reaction, some people have more, but it's not allergy. No reason to think it's allergy. So it's basically, I think, a worthless diagnosis. We should stop using this. It's more of a scare tactic than anything. Next. So the hysteria has been caused by this Oxford pseudotumor story, which I've gone through to explain to you step by step, and also because the DePuy ASR was a fiasco. I mean, not all DePuy ASRs failed, but about 30% by 5 years. So it's a big deal. And the Zimmer didn't have so much of a wear problem, but cup ingrowth problems, about 20% or so. So that's totally unacceptable. That's not good, and they needed to be recalled. No doubt about it. And a lot of these large metal-bearing devices had a total hip version too, and they had added problems at the trunnion. So the studies would show that you'd have X% failures on the resurfacing version, but more than that on the total hip version, because there were more debris released by trunnion corrosion, which it's too much to go into here. But anyway, that's out there, and the total hip versions tended to be more problematic. And all this together has led surgeons to be real negative about it. Just click through this. This is too much So my definition of an adverse wear failure is a high ion level, and I use 10 as a cutoff, plus an inflammatory mass on some type of a 3D study, a malpositioned acetabular component, and then you confirm it by seeing metallosis in surgery. That's what an adverse wear failure is. Next. De Smet is really the guy who led us down the correct path, where Oxford took us down some crazy side path that doesn't make sense. But he was the first to sort of point out that he had some of these people with painful hips. He revised, he found a lot of metallosis, and he noticed that the cups were steeper on those than the other revisions he did for other reasons. And then he started doing metal ion levels. He's really the leader in this. He convinced me to start doing it later on.
AIA? AIA, sorry.
Acetabular inclination angle.
Thank you.
So steep cup positions were correlated with this, and then he came up with this concept of coverage arc, which is complicated because it's part design. Like the ASR had a shallower cup through all the implant sizes. Thank you. The other, all the other brands, just by Quirker design, the smaller sizes, the 44 bearings have a shallower cup than the 60 bearing size. So that's why the smaller implants are more likely to go into this edge loading problem. And then it's a matter of implant positioning. So it's an interplay of all these things. But basically, if the cup is too steep, you get edge loading, and then you get too much wear. Okay, so here, this is a picture of the Biomet cup in cross section, and size 40, the smallest one, has a coverage arc 155, and the largest one has 163. They all are 180 degrees here, but just by the way we defined how these were to be designed, it turns out that the coverage arc gets smaller with the smaller implant sizes, and that's what's behind women and smaller sizes having more wear failures. That's what drives this problem. Next.
So there it is.
Okay, so here's my little drawing that illustrates the principle. And again, Kuhn de Smet was the first one who kind of showed us this, and all my data confirms it. So if you have a really big cup, they're a little deeper, and you put them in a reasonable position. This is the line of force on that hip. The wear patch is buried. You got a good fluid film, and it puts off just a little bit of metal, and it works perfectly. You have one on the smaller end, and you put it in a similar position. It looks about right, but the wear patch is on the edge, and you get runaway wear because you lose your fluid film, and then the wear rate goes up, and you get all the metallosis problems. So some people say, don't do these, but you can just do this. Just put them in a little more flat. You can bury the wear scar, and they wear just fine. And that's what I do. Since 2007, we've been doing this. We don't have a single wear failure problem. All right, next. Cobb in England did some CT studies so you can get a little bit more accurate three-dimensional picture where the implant is, and he basically confirmed what Kuhn de Smet had already shown, and what I also confirmed next. So I published the largest series of research looking at this wear failure problem. I have 8 in the first 2,600, and those are the rates of failure. And unlike the Oxford group, I confirmed what Dr. de Smet taught us. It's steep cups, smaller bearing sizes. We always see metallosis. And you interestingly always see this alveolar histology, which Willard said was allergy, but it's not allergy. It's just the tissue response you see to cobalt chrome, but it's not allergy. You see it with all these wear failures. Next. And then we did further studies because we knew it was this. We knew this concept of the coverage arc that Kuhn had come up with, and we knew that it had to do that probably the smaller cups needed a little bit different positioning. So we looked at 760 cases where we had standing pelvis X-rays and ion levels, and we did this multi-dimensional analysis, and we found a strong correlation between implant bearing size, inclination angle, and ion levels. And we defined a safe zone. We published this last year, and this is the first safe zone ever published that actually is validated by scientific evidence. There have been some so-called safe zones for total hips, but the evidence doesn't support them. This is really the first one that's done it. Sorry, it's super complicated. I'm only showing a couple slides from that paper, but inclination angle, bearing size. Basically the message, this is the 99% confidence curve, this is the 95. So this is the one we use. Smaller cups, inclination angle need to be smaller to avoid wear problems. So above this, we see high ion levels. These are all our cases with high ion levels. These are all the wear failures, and these are the 2 dislocations. So all the problems occur when the cup angles are above this line. Below this line, we have no problems. And this is very robust statistically. Go to the next slide. So this is basically what I showed you on that previous slide about tilting the cup lower. So we had all these cups in different positions, and we noticed the ones that were flatter didn't get the problems, and the ones that were steeper did, right? And we defined what that cutoff is. And it's a very complicated statistical analysis. Okay, next.
That's not going. It's not going.
Do you think it's too hot? Do you think the computer got hot?
It's okay.
It's a brand new computer.
Try that. This is the one I've been doing.
So just so you know, where you are now, you're off camera. So generally right there, anywhere from those
That
chairs
question
over
mark
is
just
fine.
appeared. See, that question mark's not in the slides.
Why is this whole thing on the bottom there? Yeah. There you go. I've never seen that happen before. So this is a simplified chart of that. So again, just a brief example. For bearing size 40, you got to put the cup angle at 32 degrees if you want to be 100% certain you're not going to have a wear problem. And if you have a 60 bearing size, I've only put 3 of these in. I think I've only put 1 of these in. Women are usually around here. Men are right around here usually. So you can have that one up at 60 degrees and it's okay. So to say that there's a certain cup position that's acceptable is really oversimplified. It's wrong. It's based on the bearing size. And it makes sense because the shallower cups, you got to tilt them more to get that wear scar buried, right? That's what that shows. It's just a fancy way of showing what Kuhn de Smet already taught us a long time ago. But these are hard numbers to show you it actually works. Next. Then you might say, okay, you've got these really tight rules about how you got to put the cup. Can you really achieve it? I mean, you've got a patient lying on their side and not standing. How do you know you're right? Well, we've developed an X-ray technique where we basically get a pre-op. We get a pre-op standing X-ray, and then we mimic that in surgery. And when we do that, we can always get it right. So when we put it in surgery, we measure it. We know it follows that guideline. If it doesn't, I change it. And then when the patient stands up post-op, we verify, yes, we got it there. And we've been doing that routinely. And we haven't had a single case with high ions since 2008, so we know it works. Okay, so what about revision of these? These were horrible cases with dire consequences, Oxford says. And you got to aggressively debride them, you got to put metal plastic in. I didn't buy that, and I didn't follow the recommendations. I thought it was a bunch of nonsense. So what I did instead was try to preserve the metal bearing because I didn't want to put an unstable bearing in when there has been some loosening of the tissues and so forth. So we revised them all to metal bearings. We put them in a better position because we reasoned if they're too steep enough edge loading, if we correct that, we should be able to get rid of the wear problem. So that's what I did, and we were able to do this surgery with no complications. Not a 50% no complications. And interestingly, 5 out of the 7 cases of these, I've done more since then, but these have minimum 2-year follow-up. Interestingly, 5 of the 7 cases had a metal bearing on the other side who never had a problem. So how could it be allergy on one side and not the other? And how could it be an allergy if you correct the position and the problem goes away? The ions drop away, the pain goes away, the patient functions normally. Kuhn de Smet's theory makes sense. The Oxford idea doesn't make any sense. It doesn't fit with what we've learned. Next. So most pseudotumors are actually wear failures. They are not allergies or other things. And edge loading causes this high wear. Edge wear loading is caused by implant design and positioning it, interplay of the two. And it's a little complicated. And edge loading can be prevented by correct placement. And you can even do it in small sizes if you're careful and you know these rules. If you follow the rule that 50 degrees is the upper limit for everybody, you're going to fail on the smaller sizes. And we can always achieve it, and we can have metal ion levels that are in the acceptable range. A lot of surgeons don't buy it. Problem is they sometimes don't get standing x-rays, so they think their component positions are okay, but they're really not because they're not getting the right x-ray. And that was really the problem, I believe, in Oxford. I haven't seen their x-rays, but I think they just had bad x-rays. And so there's not everybody changes their position when standing, but there's a small group, and these tend to be, in my anecdotal experience, the dysplasia patients, the small sizes. They tend to be very flexible and they tend to tilt their pelvis and it opens up the cup and exposes it to edge loading. So the old recommendation is based on experience and opinion, but not on data. We've got to use a different guideline. And it doesn't, of course, apply to these implants because they've got separate problems. Next. So just an example to illustrate this. A 46-year-old man who called me up 2 years after his resurfacing done somewhere else by a high-volume total hip surgeon who didn't do too many resurfacings. He wanted to be a high-impact athlete. He was a young man with osteoarthritis. He was a perfect resurfacing candidate. He got his resurfacing, and 2 years later, he's having problems with these ion levels. And a CT scan just showed a small fluid collection. It wasn't that big. Next. What did the surgeon tell him? Well, your component is in a good position. It's 46 degrees. I'm not sure why you have high ion levels. I think we've got to revise you to a metal plastic total hip. 46-year-old guy who wants to play soccer. So fortunately, he called me up. And this is the x-ray he sent. This is, of course, a totally worthless x-ray to judge component position on. It's an AP. It's rotated. These are the kind of x-rays I got before 2007, but you can do better. So when he came to me, these are the x-rays I got. You got to get a pelvis x-ray, so you can see there's a little rotation there, but that's not much. That doesn't throw off the angle measurement too much. And I measure an inclination angle of 46? No. And when he stands up, you can see that the pelvis is different qualitatively than here. See these obturators get a little bigger in this dimension? That's a sign that the pelvis is tilted back a little bit. And then when you measure the angle, it's 64. So he doesn't do a lot of it, but he does a little. So his position actually gets worse on standing. So a 64-degree angle, and it's also got something called anteversion, which is a little more difficult to see, and it's hard to measure. But so he had a malpositioned cup. It wasn't 46 degrees. And so what we did is revised his cup. We took it out and left the femoral component. We put, Birmingham makes a 2 millimeter thicker cup, so we put that in and we put it in at 31 degrees, and that's a standing x-ray. Okay, so that's a good cup position. And next. 2 years later, he's got a perfect hair SIP score. He's back to playing soccer, and his ion levels have dropped back down to the normal level. So this is not an allergy. He doesn't need a metal plastic total hip. This is the way to fix these problems. You can't always, because you can't always. Sometimes you lose too much bone, and all the companies don't have thicker implants. So you can sometimes do this, but the problem is not the metal. The problem is malposition. Next. So this is what happens to blood ion levels. They rise for the first year or two, and then they come down, and then they keep tailing off. So this is from a lot of different studies. If you have a metal wear failure problem, if the cup is malpositioned, it goes through that run-in phase, but then it gets edge loading and it keeps going up. So we measure them at 2 years because we don't really know what's going on in here so much. But if you're 2 years and you're in a reasonable level, you're just going to keep going down. If you're 2 years and you're up here, then you're probably going to keep going up. There's some in-between cases, but that's the general rule. So if you've got a good level at some point in here, you're probably going to be okay for the rest of your life. But we don't know that for sure, but that's currently what I believe. And we're doing further studies. Eventually we'll publish some stuff to see how it changes over time. All right, what about systemic toxicity? So we talked about allergy, we talked about what about systemic toxicity? These are the 6 case reports in the literature. Tower is from Alaska. He published it in a little obscure Alaskan journal. These are the levels, and these people had signs of systemic toxicity. And he revised them, and they got better, but they didn't totally go away. The other 4 reports are actually in people who had ceramic head fractures. Ceramic debris was left over. They put a metal on plastic joint in. The ceramic chewed up the metal, and they had super high levels. So these were not problems with metal bearings. These were problems with ceramic on ceramic bearings or ceramic on plastic. They had ceramic heads that fractured. Okay, so only 2 cases in the literature where you have toxicity. How many thousands have been done? It's what is the media saying? There's no rhyme or reason to all this. Next. Cobalt and chromium are part of our diet in biochemistry. Some of our enzymes have both of these elements in them. Chromium is in most multivitamins. Ions, when they're put off from your implant, are absorbed in the tissues. They go into the blood. They're put out in the urine, and you develop a steady state. You get more ions for sure if you have an hip implant than you would in your diet. But it's not like a totally foreign material. It's in our biology to some level. It's not really clear what a bad ion level is 100%. So these are some general reference ideas. The laboratories, they vary, but less than 1.5 is often what they say is okay. And cobalt is the one we think is the most problematic of the two. But
Why?
there seems to be more, if you do like tissue culture studies and stuff, cobalt seems to be more toxic than the other one. So there's some toxicity to it, but it's not enough to cause systemic toxicity. So this causes a little bit more problems for the cells than chromium does, we think. A metalloplastic total hip can put off a little bit if the mean level isn't above the normal range. One study on total leaves out of Germany showed that the mean levels were about 3.3. That's the only study out there. DeSmet took his very best resurfacings, and their upper limit of their range was 5 micrograms. So that's like in super well functioning resurfacings. This is kind of what you expect at the upper level. And in my data, the lowest, my wear affiliate example I showed you had a 15 microgram level. On average, there's about 70. So that's the kind of levels you typically get with wear failures. DeSmet has some data coming out now that there might be some toxicity developing around 20, some systemic signs. It's not published yet, but I've seen it reported in a conference. So these are my wear failures, and that's where I get my idea about the ion levels. So I think a 10 is when you should start looking for problems. Next. So this is the data from DeSmet, and you can see these symptoms of systemic toxicity. You're doing questionnaire studies. They're pretty vague symptoms, and they see more people reporting these kind of things with levels above 20 than below that. So there's some evidence that there might be some toxicity at those kind of high levels. Next. So allergy probably doesn't exist. Where is the implant design and positioning problem? I think ion levels are an excellent screening tool. Not everybody believes that yet, but I think Kuhn-DeSmet is exactly right.
Prior to?
Sorry?
I'm sorry, do you mean prior to?
No, afterwards.
Afterwards?
Just to make sure you're not wearing it abnormally.
Okay.
So you can get it's a good screening test. It's not an absolute criterion. There's no cancer risk. There's no higher mortality risk. Toxicity might occur at higher levels. So what do? If it's levels below 10, I think that's okay. That looks fine. We've never seen a problem. Above 10, I start doing testing, and if there's a giant fluid collection, I would do something. But if there's no major fluid collection and there's no symptoms or mild symptoms, I just watch those. If it's above 20, even asymptomatic, I probably would revise, because there's some evidence coming in that at that level you can have some systemic toxicity. Although I've never seen it, even in my cases that are 70, I've never seen any really good evidence that there's any toxicity. But that seems to be the conservative approach. It's pretty hard to get levels above 20. Next. Well, these are the problems in summary. Poor surgical technique and bad science, bad design, bad ingrown surface, and then some trunnion design problems with the total hips, which we really don't have time to go into, has led to the conclusion of a lot of surgeons that all metal bearings are bad. But it's not really true. Next. So that's the negative, and there's a hint of a positive in there, but there's still a lot of learning that we have to do for people to really understand these problems. There's a lot of disbelief among orthopedic surgeons about this. So now I've got some a little bit more positive results. I think resurfacing is really the best operation you can do the hip, and here's some data to show that. So these are my survivorship curves. This is Kaplan-Meier statistics, and this is my first group of Corin that I did the FDA study on, and the long-term survivorship. So in the Corin hybrids, 10 years, I have now 89% survivorship at 10 years. That means 11% have been revised at the 10-year mark. And the next group I did, the Biomet Recap cemented ones are performing better. And the uncemented ones, this is my biggest group, these are 2,500 patients now, almost, are doing even better. We're at a 7-year survivorship of 98.5%. So it's obvious that these curves are getting better. It's not just the uncemented implant, it's how we do things. And I'll show you a couple things that we've done. We try to look at the problems individually. Each individual failure mode has a cause, and we've got to try to discover those causes and then try to develop strategies to avoid them. Resurfacing is a slightly different operation than total hips. The problems are slightly different. And to do this, you have to keep a good database, keep good data, follow your patients, and then you can do good science. Next. So these are the improvements in these areas that we've made, and that's what's driven our improved results over time. A lot of things, not just the uncemented implant, but those were the patient groups, so it's easy to show it. Next. Early femoral failure, fractures, and necrosis are the early problems, so people have studied them a lot, and there's a range of reported incidents in the literature. My rate is 1.5 and 0.4, and studies showed these were the high risks. These are the things that were associated with these failures. The cause is really multifactorial. Next. Because women and old age were risk factors that everybody saw, we reasoned it's got to be bone density. So we started measuring bone density instead of just trying to exclude women or trying to exclude older people. We measured bone density, and then we saw then we did a multivariate analysis, included all these factors, and we found that when you do a multivariate statistical analysis, you find the most significant factor in any that are tied to that drop out. So age and gender fell out because it's really bone density. They were just markers, crude markers for bone density. But if you measure bone density, that's really the cause that leads to fractures. And people who are heavier, whether it's muscle or fat, doesn't really matter. I don't think it's just heavier people. So that makes sense, kind of. These fractures occur in the first 6 months. If you weigh more, you put more stress on your bone, and if the bone density is weaker, then you're more likely not to tolerate that stress. So those are the high-risk groups. So what did we do? Exclude the high-risk groups? No. We tried to put them on a slower weight-bearing program, and we gave them a anti-resorptive medicine. Fosamax prevents bone resorption. And there was evidence that people go through a resorptive phase for about 3 months, and then by 6 months they're back to normal, and they no longer have any fractures. These problems happen early on. So we took after we found this evidence, then we started putting those people on the high-risk group on this program, and we totally eliminated fractures in that group. Then we took the intermediate group that had about a 1% fracture risk. This group had an 8% fracture risk, and it went to 0 with our treatment. This group had a 1% fracture risk, and we've now put them on it. We don't have data to prove it yet, but we've had one fracture in all of our cases, 1 out of 1,500. So we basically solved that problem by doing a little science. Femoral cysts were reported to be a risk factor because it kind of makes sense. You got holes in the femur, you're trying to fix the femoral implant, and if you have more bone destruction, it's not going to be fixed as well, and you're going to have failures. AMSTUD's had some data for this. We looked at ours, and we didn't find a difference in people with cysts, or we didn't. But we did it a little differently. I put bone graft in those cysts instead of cement. Cement heats up and kills bone. So I think that was the reason. Anyway, we've shown that cysts are not a risk factor if you fill them with graft instead of fill them with cement. So that opens up resurfacing for a lot more people who might have been worried because they have a cyst, but it doesn't affect the outcome at all. Femoral loosening. I always thought it was a bad idea to cement implants when we already knew that uncemented implants were more durable than total hips. So why did we go to resurfacing for young, active, vigorous people, and we put this acrylic cement in there, which is prone to fatigue? I never liked it, but I didn't have a choice at first because I didn't have uncemented implants. So it turns out cement was my number one failure mode with the resurfacing. As we went further out, we developed an uncemented replacement and started using it in 2007. And so far we have had no case of femoral loosening, but they're only out to 7 years yet, not 10 years. We've had no cases of failure of bone ingrowth. So a lot of people who don't, most surgeons still use a cemented femoral component, and most companies don't offer it uncemented, but surgeons are worried that the bone won't grow into these, but we've not had a single failure of bone ingrowth. So pretty amazing data, 2,500 cases. Mm-hmm. I think we've solved that problem, but until we get to 10 years, I can't say for sure. The two most vexing problems have been the adverse wear problem, which we've already discussed in detail before, but the other problem is failure and dysplasia. These are typically young, highly flexible women with small bones. They have a higher incidence of problems with any kind of hip replacement. And that's sometimes what's missed when people say you're not a good candidate for resurfacing because you have dysplasia or you have a female with a small bearing size, because they're often dysplasia. And the risks that have been documented in resurfacing are femoral failure. I've not seen this, but others have. Socket fixation, this has been my number one problem, and to a lesser degree I've had that problem. And my first study I published looking at dysplasia and what might be causing the problems showed that most of our problems were fixation failures, and we had some wear failures, in that group too. Next.
It's a fixation failure.
Attaching the implant to the bone. So you have an oval, shallow socket, and you've got to make it round to fit an implant. And if you can't make it totally round, the wall, it doesn't have as good of a grab in the bone. And then while it's trying to heal, it spins out or it doesn't attach. That's the basic problem. And it has to do with the shape of the socket. People with osteoarthritis don't have it. They have a normal shaped socket. So was my major problem with dysplasia. We just had a cup that you can press in. We didn't have any extra screws or anything that you can put in with total hips, right? So we didn't have that supplemental fixation. So this deformity, of course, comes in a spectrum. They're mild and they're severe cases, and the severe ones have more of these problems. And they're also typically women that are smaller boned and need smaller implant sizes. So as I already explained, it plays into this wear failure problem because those are, we now know, a little more challenging to place. So this is what we just explained. And if you have, the surgeon also to some degree gets fooled a little bit. They have a shallow oval socket and their landmarks aren't so good, and so how do you place the socket? And if you put it too steep, then you get the wear failure problems. If you put it too shallow, the cup's really uncovered and then it spins out, so that's what you're struggling with. And some people have a little more of one problem versus more of the other. I suspect the Oxford people followed the bone more and had more wear failures, and I put them down and I had more of the fixation problems. So here's a little illustration of the problem. The socket's a little bit oval, but there's a lot of good bone here. And you put your reamer down here, which is a sphere. You ream into that. Go to the next one. And you gradually bring your reamer up and you capture this oval. And if you get it pretty round, the cup will stick. If you have too much of a defect here, then the cup might spin out. So we kind of had this idea that 30% coverage was the problem. That's when we started having the loosenings. This is just from my anecdotal experience. So next. So Biomet came out with a tri-spike in 2007, so this gave me supplemental fixation. You can't put screws through the cup, but you can do this. They're a little tougher to put them in. You can't move the position, so they're a little technically challenging to put in. But ever since we've started putting in these, we've never had any cup failures anymore. So don't put them in all of them. Go back. Don't put them in all of them, just in the ones that have. When I get done preparing them, if there's 30% uncovered to my eye, then I use the tri-spike. And using that protocol, we've had no more cup failures since 2007. And there were other improvements too, right? So we had better positioning that we talked about before, and a fracture prevention protocol, and uncemented femoral fixation. All these things were on board by 2008. So we're looking at our results from 2008 on next compared to before that, right? And this is a little different group of patients than the previous study, but this is the previous group. At 5 years, I think, is about right here. We have 93% survivorship in the previous group, and the new group, we're out to about 5 years. Here we're 99%. We've in fact only had one femoral neck fracture in 168 cases with minimum 2-year follow-up. So it's pretty easy to see that that's a better curve than that one, and we're doing better. So
is that your sample of what that 168? Does that apply to this curve?
Yeah, that's these patients. 168 patients applied, and these were like 140 patients or something like that. It's going to be in the paper, but it's going to be published hopefully this year. But basically, we've solved the problem of dysplasia. We can do them with minimal risk, and I don't think there's any paper in the total hip literature that shows that good of results at 5 years with dysplasia. So we're now outperforming the best of the total hip literature. Next. And these are the group of people that are high risk and that you shouldn't do resurfacing on. But I'm proving that you can do resurfacing on them.
High school.
What is this slide? This is the just recapping the adverse wear-related failure problem, how we've addressed it and gotten better, and without patient selection, without selecting against the small sizes that everyone else says. We do them, we just get the cups right. And we basically have had no wear failure since 2008. We've got have a little bit more time pass before we can publish something that has statistical significance. But I think we've solved that wear failure problem. But there's still some people with unexplained swelling and residual pain. Well, if you do total hips, in general, about 20% of people have residual pain. So it's not a perfectly normal joint. And I think it's similar with resurfacing. You're going to have some residual pain. But what about if you have residual pain and some swelling? What's causing that swelling? I've got 4 cases like this I can't really explain. Well, someone might call these allergy problems, maybe, but I don't know. I'd just like to keep it as unexplained swelling. I don't really know. 2 of them I revised to metal plastic. They're less than a year out, so we'll see if that resolves their problem or not. Hopefully, they seem to be doing okay. One I did a psoas release. I thought it was clinically a psoas tendinitis problem that was causing swelling, and she's 4 or 5 years out from that and doing well. Haven't rescanned her, so I don't know if she has swelling, but she's feeling good. And one is about a year out now. He has swelling. Everything looks good. His ions are good. Everything. I'm not sure. So there's still some unexplained cases, but you've got that with joint replacement. You can't explain everything. It's a pretty small number. Next. All right, other advantages, eliminating transfusion. We basically have put in a lot of work into getting this surgery less invasive, losing less blood, and preserving blood and everything, and we basically don't transfuse people. Next. What's that compared to? The national benchmark, about 20 to 30% of people with total hips get transfused. And of course, most of us put people on anticoagulants, blood thinners, to prevent blood clots for about 2 weeks. That makes you bleed more. But despite all that, we can do it with virtually no transfusions. Now, minimizing infection risk. There's a ton of things we do. It's too much to go into. Next. Gradually, we've come up with more and more ideas. What's the national benchmark? About 1 to 2% deep infection with total joint replacement. My rate's way below that. And both of those cases were cured by aggressive treatment with intra-articular antibiotics. So we haven't lost a single implant due to infection in many years. And it way beats the national average. What about pain control?
What do you attribute that to?
All those things before. We can talk in detail if you want later, but it's going to take a long time. We don't have a lot of time.
Sorry, didn't see that one.
Pain control. The old theory used to be give them general anesthesia, and then when they wake up and they're screaming in pain, then chase them with narcotics. That's not a very good way. We've gotten a lot better. A lot of surgeons have, but not everybody. We use a multimodal pain management system. We don't have anybody on morphine pumps. We occasionally have to give a little bit of morphine after the surgery, but most people can manage with these oral regimens now, since we have combined a lot of different ways to attack the pain problem. Next. So doing all that, if you have an implant that's stable, that's not going to dislocate when you bend too far, and you've got you're sure you're not going to need to transfuse them, and you've got pain under good control, then you can even do this as an outpatient procedure. And we're going to report for the first time in the world our first 100 cases at the South Carolina Orthopedic Association this August. But we can do it. We've done over 100 so far. We're picking the healthiest people. If you've got some kind of a prostate problem, we don't want to do you. We're picking the best ones right now, and then we're going to try to gradually expand it. But we can do it, and the people are very happy with it. Why do it? Well, people don't like to go into hospitals. If you do it so well they don't need to go to hospital, there's a perception that it's less major surgery, and psychology has a lot to do with healing. So if you can influence the psychology, I think it's a good thing. We give patients the option if they meet the criteria, and certainly the cost is significantly lower. The cost of this, it's a problem. Cost of medicine is a problem. We're trying to do what we can to minimize the cost for people. So what do you have to do to do outpatient surgery? You have to do, I think, minimally invasive surgery. You have to eliminate transfusions, have a stable implant, good pain management. Right now, only Blue Cross is working with us on this. The other companies are a little slow to catch on, even though it's to their best advantage financially. We do need to have people stay overnight. Like even if they're in a local town outside of Columbia, they need to stay overnight before going home. So just in case there's a problem, and they need to have someone with them at the hotel overnight or at their home if they're local Columbia folks. But I'm doing people from Canada, from California, whatever, outpatient. They stay in a hotel if they meet the criteria and they want to do it. Next. Over 100 cases so far. We've had one ER visit for a bladder problem. It resolved. It didn't turn into anything, but we had a little worry there. No major complications, no hospital readmissions. So far, so good. We're going to keep working on this. Just a note about what's the better hip implant to have. I think resurfacing is much more durable. I think I've given you a lot of evidence to show that it works very well. I think in patients under 50, these are the people who are the most demanding on their implant, the most likely to have implant failure. We have better survivorship than total hip can demonstrate with resurfacing. Not every surgeon can show it, but a number of us can show it. We have less bone removal. We create a hip that's biomechanically more like the normal hip. So in gait labs, you can show the difference. Walking down the street, you can't really tell the difference between a total hip and a resurfacing. But if you do a gait lab, they almost always show the resurfacing is superior. And people go back to full impact sports, heavy labor, and they don't have to worry about bending their hip too much doing ballet or gymnastics or getting in a kayak because it won't dislocate. Next. So this is from recently published from the Nordic Arthroplasty Register. Total hip survivorship at 10 years is 83%. My personal data on resurfacing. Less than half the failures at 10 years. So if the FDA were to get rid of resurfacing, I think it's a bad idea. We're doing a disservice to young people. Just because some people can't do it doesn't mean that the operation shouldn't be out there, because we can demonstrate a lot of advantages of resurfacing, including implant survivorship. Not everybody can, but I'm not the only one who can show it. I mean, and we're getting better and better than that. We're already beating total hips, we're getting better. So I think metal ions are a very useful monitoring tool. Kundasmet was the leader. I'm so glad I started doing that in 2007, and it's helped me a lot to solve some of these problems. These ions are highly unlikely to damage your body. The risks are way overblown in the media, and I've shown you some scientific evidence to show that it's really not much of a problem. Adverse wear failure is a problem, but it's totally preventable, and it can be corrected. It's not the horrible problem with dire consequences, as Oxford and others have said. If you know how to revise these, and Jim Pritchard in Seattle has a very good track record of revising these too, and so does Kundasmet. So, I mean, there are some of us who can fix these without horrible consequences. If you have horrible consequences, routinely you're doing something wrong. And metal allergy is a hocus pocus concept, I think. We've solved a lot of the problems. Early femoral failure is 1 in 1,500. Femoral cysts are not a problem. Loosening, we don't have any more loosenings of the femur. Acetabular failure dysplasia, we've had none since 2008. Adverse wear failure, none since 2008. No blood transfusions, rapid recovery, outpatient. It's getting better and better and easier to get this done. It's the best hip operation there is, in my opinion. But it's under threat. There's still a perception that all metal bearings are bad. There's media hysteria, and there's a lot of surgeons just don't understand the facts underlying this. They have a very simple-minded concept of what the metal wear failure problem is. And unfortunately, a lot of them put in the debut ASR because that was their favorite brand, and they did a total hip, and they didn't do well. So they have this idea that they're all bad, but they're not. We're going to need some help, probably. I've got to figure out how to do this, but I think we need to start a grassroots campaign to contact congressmen and contact the FDA. I'm not sure who exactly it is in the FDA to contact yet. I intend to put something out on my website and maybe through Surface Hippy, and I need some help so that the FDA continues to remain open to this idea of resurfacing and not close the door, because they don't have to just ban it, which I don't think they can really do. But if they just make the requirements on the implant companies too tough, they're going to throw in the towel, because they don't have endless amounts of money, and they're not just going to burn their money. So if the FDA makes it too expensive for implant companies, they're going to give up. And then you can still go to Europe and get it, because I don't think they're going to shut it down in Europe. But it'd be a shame if we shut it down in the U.S., I think. Thanks.